Deaths from sepsis are preventable. We need to do better. I chaired the Maternal Mortality Review Committee for the state of California for 15 years, and over 90% of the sepsis deaths were judged to be preventable. We also noted in our reviews of maternal deaths that 90% had one or often more of the three deadly Ds: denial, delay, and dismissal. These are themes that are going to be present in many of the cases that we discuss and are foundational for our work. Next slide. The next why is, why are we doing so poorly with maternal sepsis? After all, we know how to treat sepsis. We spent a year in the first part of our project interviewing nurses, physicians, and midwives, and this is how they answered. Sepsis is relatively rare. Its definition is not standardized. Diagnostic approach is not well established. Treatment's often delayed, and there's a special challenge of chorioamnionitis. We also interviewed patients and family members of persons who passed, but they answered differently. Patients and family members did not know the signs and symptoms of sepsis. They did not know how to best advocate for themselves. Sepsis was not on doctors' or patients' minds, so the symptoms were dismissed. Half of sepsis cases were present in antepartum and postpartum, with especially delayed diagnosis in those settings. These are issues that will be addressed during the sprint, but let's start first by listening to a patient story. Next slide. No sound, Ruhi.
Ruhi, you're gonna have to reshare with audio.
Sorry, 1 second.
Of course I am. Smile for me, Chris. Hi. My husband and I had been struggling to get pregnant for quite a while. Finally, in 2016, we found out that we were pregnant. We were over the moon excited. Everything went smooth. I didn't have any conditions going into it or anything that had me scared. I was supposed to be discharged 3 days after I gave birth, and on that third day was when I really started to feel bad. My white blood cell count was elevated. I had fever, and I was jackhammering in the bed with chills. I was so cold. Instead of digging into why I was having those temperature fluctuations, they called the maintenance people to my room to come and check the thermostat. At first, I felt like my heart was just gonna beat out of my chest. I felt real anxious. I couldn't stand up. I would get out of breath, but all the doctors kept telling me, well, you just had a baby, you're exhausted. It's normal to feel anxious after. You're probably just nervous about being a new mom. Everything that I said was just kind of explained away or brushed off. I felt like they're the experts here, and maybe this is normal. Maybe this is what all new moms feel like after childbirth. When they sent me home, they gave me a prescription for anxiety medicine. I don't feel like they ever took me seriously. They decided that I was an anxious new mom, when in reality, my body was shutting down on me. I tried to care for my newborn son, but I couldn't. I couldn't even care for myself. I started to get sicker, and my body started to shut down on me. I was coughing up blood. Finally, my mom convinced me that something was really wrong and we needed to go back to the hospital to see what was going on. I was still very nervous to go back because they had already told me that I was fine. I remember on the way there feeling like it wasn't going to change anything.
When we went back to the labor and delivery and she was admitted, she
just kind of lingered there. There was really no action.
They didn't really have any answers. I laid in a bed there and continued to grow weaker and sicker.
When I saw her blood pressure dropping, I brought it up to the nurse. I said, her blood pressure's getting lower. And she said, oh no, it was that low when she gave birth. I looked at her chart. But finally, in the middle of the night, a doctor came in, and that's when I first heard that her kidneys were shutting down. It took probably a couple hours before the rapid response nurse came. He asked her how she was doing, and I told him she's not okay. And he looked at her chart, and he said, follow me. And he took her up to the ICU, and that's where I found out how really sick she was.
Once I was in the ICU, that's when they started to tell my family that I had gone into septic shock. My kidneys had shut down, my liver. They said I had developed an infection in my uterus that had led to the septic shock. All of my organs had started to shut down, and they weren't sure that I was going to make it.
For the next 7 or 8 days, she never woke up. They had her intubated the whole time. They were pumping her full of medication to try and raise her blood pressure, and one of the doctors told me people who are as sick as her are usually on 1 blood pressure medication. We have her on 3, and 2 are maxed out. We can't give her any more.
At one point, they told my family to call those that were closest to me to say goodbye because the odds were not looking good.
I didn't want anybody to come say goodbye to her, because if they came to say goodbye to her, that was it. So I didn't let my family come. I told everybody, stay away. I couldn't give up on her.
I laid in that bed fighting, and during that time, my husband had to start thinking about, what if he has to raise this baby on his own? What if my son grows up without a mom? That's the scariest part of all of this, is that by not listening to me, by brushing me off, by me not knowing those warning signs, it created this perfect storm that nearly cost me my life.
About 7 days in, it looked like she was gonna pull through. They told us that the following day they would take her off the sedation.
I woke up so confused, and I was strapped to a hospital bed. I didn't know where I was at. I didn't know if I had had a baby. I didn't know if all of this had been a dream or a nightmare. I had a tube down my throat. I couldn't talk, couldn't communicate. I was terrified.
We want to thank April Chavez for sharing her story. This is an important grounding for all of us as we look to take care of patients with sepsis. I think you heard pretty clearly examples of denial, delay, and dismissal. Next slide. So today's sessions, we have 3 different topics to discuss. I'm going to lead off, followed by Lori Olvera talking about implementation at Sutter Health. Lori is a nurse educator who's implemented sepsis at multiple Sutter locations. That topic will be definition and screening tools. That will be followed by Christa Walczak at CMQCC, our clinical lead, and Jenna Ogborn from Long Beach Memorial Hospital talking about bedside evaluation and documentation. Our third topic today is using the EHR for screening and nurse-driven pathways, introduced by Courtney Martin, a QI lead at Hoag Health and a state and national leader in QI, with Daisy Ramos from Loma Linda University, who's implemented these pathways at her hospital. Next slide. So the diagnostic criteria for sepsis has changed in our professional careers. It started off in 1992 as infection plus 2 or more abnormal vital signs, or SIRS criteria. And then in 2016, international consensus was developed called Sepsis 3, which redefined it as life-threatening organ dysfunction caused by dysregulated host response to infection. So now it's really focused on end organ injury. Sepsis 3 was adopted by WHO, CDC, ACOG, Society of Maternal Fetal Medicine, and every other national professional organization. CMS, though, still defines sepsis as infection plus SIRS. However, they also define severe sepsis as sepsis with end organ injury. And this is the measure that's used in Sepsis 1 measure that's reported to CMS. Note that this severe sepsis definition is the same as what Sepsis 3 calls sepsis. So we'll keep that in mind as we go forward, particularly in our third session when we talk about QI initiatives. Next slide. So we have sepsis as a small subset of overall patients with infection. The concern, however, is that Sepsis 3 definition of sepsis that requires end organ injury may not promote early intensive treatment of severe infections in time for prevention. So in our approach, we need to identify those types of infections that are most likely to advance to end organ injury. Those we call severe infection, which is a term taken from CDC terminology. Next slide. To do that, we've developed a two-step approach to identify obstetric sepsis. Use a vital sign screen. CMQCC has tested one. Muse and MERT are also out there that are commonly used, but that is only the first step to identify essentially severe or serious infection. The key next element is the bedside evaluation, and that's going to be our second topic today. But remember that we do the two-step evaluations for many diagnoses in OB/GYN that are relatively rare. Think of our approach to syphilis, our approach to cervical cancer, where we start with, for example, pap smears and then go to biopsies, or HPV testing and then go to biopsies. Two steps. Next slide. So in our teaching toolkit, we have teaching points for obstetric serious infection screen. So the flow chart. And we have 10 teaching points here. What we're going to do next is turn to Lori Olvera, who's going to talk about how she teaches the screening flow chart to the hospital staff. Next slide.
Thank you, Elliott, for asking me to talk about serious infection and sepsis. So I get a lot of questions about implementation. So before I dive into the evaluation flowchart, I wanted to talk a little bit about implementation. It's really important if maybe you're getting a new sepsis program going, or you have major changes that you want to do, is to get a group of stakeholders together and present the impact to those departments that are going to be affected by a sepsis program. It's very important. You want to identify an RN lead and a physician lead that can lead the team through the process. The stakeholders are going to go back and review with their department the impact and whether they want to be able to take it on. Then the stakeholders are going to reconvene, and then a decision is going to be made and an action plan will be developed. For nursing, you want either your CNS or your educator to train super users to be out on the floor who know the sepsis program, who can help mentor the newer nurses in the process. Goals are really important to establish. We use the antibiotics need to be given in an hour when you have a screen positive, and you want to make sure that the bundle elements are being completed in 3 hours. So that's a way that you're going to be able to measure your progress. I really love this diagram because I feel like this really shows the definitions going forward. You have infection, that's your choreo, your endometritis. Then the smaller circle says serious infection. That's your patient who is now having abnormal vital signs, plus they have an infection. If your patient goes on to get sepsis, that's the end organ injury. So it shows the smaller circle being those patients that go on for end organ injury. It's very important that you use clear documentation in your documentation, but also the clear communication when you're communicating terms, either between physician and nurses. You're going to want to only use the word sepsis in your documentation when an end organ injury is present. Avoid using terms such as rule out sepsis or sepsis without end organ injury. You want to use the term serious infection. Going on, we want to be able to screen for serious infection. Your parameters are listed below. You're looking for an oral temp that's less than 36, or it's going to be a temperature that's greater than 38 or greater than 100.4 Fahrenheit. It's a heart rate greater than 110, respiratory rate greater than 24. It's a WBCs that is greater than 15,000, less than 4,000, or you have over 10% bands. Any two of those criteria is a screen positive, and you'll want to immediately, within 30 minutes, do a bedside evaluation. That evaluation is going to be discussed later in our program, but it is usually can be done by an RN, a midwife, a physician. It's just a head-to-toe assessment to see how sick this patient really is. Some of the teaching points and things I want you to remember, things that we learned, is that a WBC must be within 24 hours. So if you have a patient that's 3 days into their hospitalization and your WBC was drawn on admission, you're going to want to get another one because it's not accurate. Fever is not recognized, is not required to diagnose infection or sepsis. They found when studying the mortality or maternal deaths that 73% never were admitted upon admission. They didn't have a fever. And then 25% of them never, ever had a fever. And those were patients that died. So it's really important to really to know that a fever, you can have somebody seriously sick and never present with a fever. Oral temperature is required. A lot of nurses want to do the axillary because it's simple, it's under the arm, and so really making sure that when your nurses are doing their screening of this, that they have done an oral temp. It's most accurate. Of course, your rectal temperature is the most accurate, but your oral temp is like what we should be doing, and avoid any axillary. Temperature elevation must be within 2 hours of your abnormal vital signs. It can't be far apart. It has to just kind of be within a couple hours. And then you're going to be evaluating whether your patient has hemorrhage or preeclampsia, because those will have vital signs that look similar to the septic patient. Next slide is on to action steps for serious infection. You're going to want to look for end organ injury. So you're going to want to do a CBC, a chem panel. Depending upon, you might want to get a lactate. It just depends if your patient's in active labor or not, because if they're in active labor, you may not want to get a lactate. You're going to look for your source. So if the source is unknown, send a UA, especially if the source is unknown, or if the patient is showing signs of a UTI, might have CVA tenderness, or just showing signs of a UTI, you may want to send a UA. If shortness of breath, the O2 sats are below 92%, you'll probably want to get a chest x-ray. Your documentation, SBAR, is very crucial in these steps. Next is on to end organ injury. That is when the patient actually has sepsis. Some of the criteria for end organ injury, and I want to call out that lactate is not a part of our end organ injury, but your patient will have hypotension. The MAP is actually the most accurate indicator for how for your hypotension. So really pay particular attention to that. Hypoxia, oliguria. If they're confused, appear toxic, agitated, unresponsive. If the bilirubin is greater than 2, your creatinine is equal to 1.2 or greater, or if you have coagulopathy, all of that is signs of end organ injury. That is time 0, and that's when the bundle elements, that 3-hour bundle, the fluids, the labs, the antibiotics that you're going to want to measure from is from this point. It's really important to audit your charts, to provide retrospective feedback to the team so they know how we're doing and things that what we can do to improve. Fluid management is very important. If you have, when they first screen in for serious infection, you'll want to get a 500 to 1,000 ml bolus in. The patients are generally especially when they're running fevers, they're dehydrated, they're intravascularly dry. So just giving some volume is really going to help. Patients with sepsis and septic shock really need to optimize the circulating volume and increase the cardiac output. So a lot of times we're schooled into giving a 30 ml per kg fluid bolus, but ideally we should be doing an ideal body weight. That came with the SEP3 definition saying that we should be giving a fluid bolus that's dependent on the height. And I'll show you a little drawing in the next slide. Patients with preeclampsia or existing heart conditions require close monitoring because you're giving the large bolus. So, and we're going to be talking about that later in our program. Reviewing the pump setup with nurses is very important because it's really important. Ideally, it's actually your antibiotics are the most important thing to give first. But actually, when you have somebody that has low BP, your fluids become equally as important. So showing nurses, we would actually be starting a second line if we had to, but your pumps can concurrently run your antibiotics and your fluids at the same time. So really making sure nurses know how to do that. So this is the ideal body weight chart I wanted to show you. And it's driven by the height. So I usually by the 30 ml per kg fluid bolus, you'll be giving 2 to 3 liters, which is a large fluid volume. But let's take somebody who's 5'5". You would be giving 1,700 or 1,710 mils. And that's a big difference. So we should be following this ideal body weight. Lactate measurements. Lactate measurements, elevated lactate is not considered criteria for end organ injury, but it is a measure of severity of tissue perfusion. Lactate, will be elevated in active labor and second stage, and CMS recommends not to draw lactate during this time. And so we support the same. Parameters, if you do draw lactate, for antepartum and postpartum, it should be above 2 millimoles. If you have an active labor or less than 1 hour postpartum, then it's the 4 millimoles or greater that is considered abnormal. Blood cultures. For chorioendometritis, it's recommended not to draw blood culture until they have end organ injury. That's very important. And if a patient has pyelonephritis and a high fever, you should consider drawing those blood cultures ASAP. Pyelonephritis patients, they get deceptively well and then they rapidly deteriorate. So it's really important to really jump on those patients and really start seeing what's wrong, because they can go, they start out with a pyelonephritis, they can go into acute respiratory distress syndrome, and they're in your ICU right after that. They get very sick. Antibiotics, if you have a serious infection, you can start out with a source-directed antibiotics. And in the toolkit, you're going to see our standard order sets that identify the source-directed antibiotics you should be using. For sepsis, the end organ injury is to go to more of a broad spectrum antibiotics, because those patients are going to just need better antibiotics to cover the sores. And then for weight-based antibiotics, have a standard starting dosage in your PICs to be followed up, because you want to be able to give those antibiotics within that hour, have no delays. Just remember, for every hour delay for your antibiotic administration in sepsis, your mortality is doubled. So it's really important, to be able to give those antibiotics within that hour. That is the end of my presentation, and I thank you.
Thank you, Lori. In the next slide, I'm going to turn it over to Christa Walczak, who's going to address bedside evaluation.
Hi, everyone. So we're going a little bit deeper into the bedside evaluation portion of the serious infection pathway. Remember in your welcome email that you received from Ruhi that there were full-scale presentations about all these things throughout the collab that you can access on the website. So we're just kind of touching on what basically the purpose of the bedside evaluation is here. And then I'm going to pass it off to Jenna from Long Beach Memorial to show how that was actually implemented and documented, or is being implemented and documented at their facility. Next slide. So really that purpose of that bedside evaluation, or this step 2, we have had a screening pathway before that didn't really include this kind of stop and think portion of the screening. This goes beyond the vital signs, beyond the lab values, and it really has us consciously put our eyes on the patient, really eliciting any kind of feedback that they have to give us, as well as the family. So in the absence of a clear alternative to sepsis as the diagnosis, we're going to go ahead and treat that infection and move into the steps to obtain more information. So this includes things like closer observation, more regular vital signs, some simple labs, and full case discussion with the team. Next slide. The components of the bedside evaluation, again called out by Lori, this can be done by an RN-CNM or physician, is really that if we're not already familiar with what our patient labs are and where we're starting at, that we want to make sure that we review that. We want to take in consideration any reports of symptoms from the patient themselves or from the family, which we heard in April's story, and perform that physical assessment where we're kind of making that observation and see if there's any abnormalities present that could be associated with sepsis or other diagnoses. So shivering, confusion, clammy skin, difficulty breathing, any kind of signs of pain or skin color associated with poor perfusion. Hopefully not, we haven't gotten that far. Next slide. We want to evaluate for possible sources of infection. So we want to take a peek at those incisions, lacerations, take a look at the breasts, ask the patient for if they have any pain with urination. Is there any CVA tenderness or other signs of urinary or kidney infection? Is there any persistent cough or abnormal lung sounds? Are there any signs associated with alternative diagnosis? What does the bleeding look like? Do we have other signs of hemorrhage? What about hypertension, edema, severe headache, or other signs of preeclampsia? If this assessment is performed by nursing, communication happens with the provider for orders to proceed, even with those initial stabilizing orders, as Lori mentioned, as fluids and antibiotics, if a nurse-driven pathway is not already in place. And Dr. Martin and Daisy Ramos are going to talk about nurse-driven pathway later in this talk, so we'll hear a little bit more about that. Next slide. Communication and documentation is certainly critical. We want to make sure that as we are communicating to the physician that we are saying when we are uncomfortable or there's safety issues present. This is all part of team steps. So if we have no reason to not proceed through the serious infection screening and then move on to the treatment phase, we want to make sure that we express that to the provider as we're getting those, having those discussions. Documentation is super critical. We want to have a very specific way that we document this in the chart so that we know where to look, not only for audits, but as we pass off patients from one nurse to another, or in some cases, one unit to another, what was actually communicated and what was found on screening. So not only the screening results, but what was found in the bedside evaluation, as well as the communication to the physician is documented in the EHR. And with that, I'm going to go ahead and pass it to Jenna.
Thanks so much, Christa. Thank you for having me. So I'm going to be talking about how we are looking to implement this toolkit at Miller Children's and Women's Hospital. Of note, you mentioned Long Beach Memorial. We are on the same campus. Next slide. Based off of what Lori said, I was happy to hear we're kind of at an overview looking at the way we're planning to roll out this education. And I feel like we're hitting a lot of the things that Lori just discussed. So we were part of the collaborative, and we did have an MD lead and a task force that had RNs. And we wanted to come about this at many angles because there are a lot of new steps to this new screening process. Like Dr. Main said, it's a two-step process. We really wanted to make sure that both our RN clinical staff and our MDs, and we have several MD groups that support our hospital, really understand the new steps that our nurses will be doing and the screening tools. So we wanted to create a really robust education for them online through electronic learning, but then also getting clinical super users. These are staff that work at the bedside, that they're on the floor every day. We want to make sure that we have some experts embedded on our floors every single day to help out the rest of the staff to make sure that all of these tasks are being accomplished and help troubleshoot. I mentioned also our different MD groups. So it's been really important for me to partner with our MD lead in scheduling some lunch and learns with our physician groups to make sure that all of our physicians are aware of the changes, the updates, that they know that when the nurses are calling to ask for orders, that we all stay on the same page and that we are not deviating from the standardization of this best practice. We also, after we assign the ULearn module, and I'm going to get into kind of the content of that, we're going to bring in our super users to give them kind of an in-person training. So that is doing a Q&A with them, allowing for them to ask questions, practice some case studies and some examples. So they really, really understand the process in a different ways that this could present on the unit. And then we did take the CMQCC tool that was created and we made a bedside companion decision-making tool. We will not have the full force of Epic behind us when we go live this spring. So we needed a way for the nurses to really make sure that they're following all the steps. Like you said, that two-step process and ensuring that the bedside evaluation gets completed. So we have a couple of tools for them, an audit tool to make sure this is happening in real time before we go live, hopefully this spring. Next slide. So the web-based training, we obviously want to identify why this is important. We have adult learners here, so it's really, really important that although we're looking for a needle in a haystack, that the staff really understand how critical it is to screen for obstetrical serious infection and sepsis. We want to start by going over our current process for identifying infection so that the staff can understand the differences, that key difference being that bedside evaluation tool. So we're not just looking at objective data. We want to really focus on doing the assessment at the bedside, and then from there deciding what pathway and what orders we need. We need to discuss what the Epic limitations are, and I'm going to get into that in the future slides. And then this online education is really that granular step-by-step, going through exactly what the nurses will be doing at the bedside, when to ask for orders, when to start this, when to do that. So they really understand what the expectations are when they're applying this on the floor. And then how to utilize the bedside assessment tool, the companion tool that we've created to make sure that they don't miss any steps. Next slide. So I wanted to talk for a minute on the limitations of our current process. So when our Epic system uses the maternal early warning trigger or mute, and you can see that really if you click it again, it'll highlight on the screen, yes, that our infection pathway is triggered exclusively by an elevated or a low temp. And as Lori explained, that 25% of proven OB sepsis cases did not have an abnormal temp. So that's going to be really, really critical for our teams to understand that the abnormal temp is not the only way to get into the infection pathway. Our algorithm through Epic and Mute does not utilize a bedside assessment, and it doesn't standardize like this process to rule out end organ injury or look at other types of infections that we might be worried about. So these are all kind of the limitations that we're up against when we're moving into utilizing the new toolkit. Next slide. I think it's really important. I think it's been mentioned a few times, this standardized process. Dr. Main mentioned it. We do a two-step standardized process for many things in OB, and something that I think we're all very familiar with when we work in OB is how we evaluate for neonatal GBS and using the EOS screening tool. And I think it's important for our staff to understand that this sepsis two-step screening tool is just like what we've been doing with the neonatal EOS for ruling out GBS. We take the objective data that we know, and then we utilize the bedside evaluation of how the infant is doing, how well do they look, and the overall picture of the baby to decide what the next steps are. So I think when you lay it out that way, and we're creating this standardized process for all of our maternal patients, it helps the staff understand kind of what we're doing. And for our hospital, we did not have the EOS calculator embedded into our Epic when we went live with it. This was something that the nurses had to do on paper to start with, where they had to write out all these values of the baby, input them into the calculator, add in their own assessment, and then they were given the tools and the orders of how to proceed. And when we think about the way we're rolling out this sepsis education, it's really like this. We're going to start on paper. We're going to answer all the questions. We're going to perform that bedside assessment, and then we're going to know what our next steps are from there. And I think that process just helps embed to the nurses exactly the things that they're looking for that normally Epic would do that decision making for them. So it really helps hardwire what the outliers are and what changes the picture. Next slide. So yeah, when we go live, we can't wait to have all of the Epic things that we would like to help us with our decision making. It won't be ready in Epic. I mean, we would be lucky if we got all of these updates in 2026. So our patients, we want the best care for them. We're going to go live without the full Epic decision making backing us, because it will take time to do that. We have to revise all those new trigger criteria, and then we are going to add flow sheet rows for the bedside assessment, and all of the BPAs that will pop up to notify you that you need to move on to the next step. So what we want to do in the meantime, like I said, is start on paper, utilizing this companion bedside tool to ensure that the staff are following all the steps, and then the reminders of how critical it is to validate the more frequent vital signs, document these physician notifications, the bedside assessment results, and escalation. And so we do have a couple things that we're able to push through that will help us when we go live in a couple months. Next slide. So this is a mock-up of our companion bedside tool. We took the algorithm that the CMQCC already has in the toolkit, and what we've done is we've just really made it really specific to the way that our unit works, our standard workflow, and the names of our specific order sets, so that the nurses know exactly what they're doing in each step and what they are asking for. So again, once we get Epic built up, this will all be embedded in there. But in the meantime, we needed a really simple way for the nurses just to follow those steps and ensure that nothing gets missed and that it's done in a timely fashion. Next slide. One of the things that we're going to be able to push out is a smart phrase note. Lori mentioned how important that timing is. And so we want a way to audit that when abnormal values are being identified, that the RNs are going through the rest of the bedside assessment and getting the right orders, and the antibiotics started in a very timely fashion. And the note will be able to help us timestamp when those things occurred, so we can see how our teams are doing while we're waiting for those Epic builds. I think it's also important to embed steps into what you're doing that are repetitive. So you can see in the note, we've got our abnormal vitals. The nurses are identifying those, followed right away with the RN bedside assessment. Then we got the MD notifications, and we start that 1 hour bundle, getting our antibiotics going, increasing our IV fluids, ordering the labs, and monitoring every 30 minutes. So if everything that they're seeing is following these steps and they're having to check them off on paper, this note just helps timestamp that for us to make sure that these steps are being followed. Next slide. So what we've requested is this future state epic documentation, the flow sheet rows that highlight the bedside sepsis or the evaluation. And I think about this like the screening tool that we use for OB hemorrhage risk. This is something that the nurses need to document on every single shift or when there's a change in patient status. And I think in getting this type of tool, screening tool embedded into the EPIC flow sheet rows just helps solidify exactly what the nurses are looking for. They have to answer these questions every shift. Were there any qualifying factors? Check those things. If yes, then you're moving on. And the bedside evaluation, yes or no to all these questions. And this type of repetition just helps reiterate the importance of doing these steps. And it helps the nurses understand if any of these things are off, it changes the plan of care because they have to answer these questions every single shift. Next step, or next slide, excuse me. And then we needed to audit. I don't love an audit tool. We don't want to do it forever, but we definitely need to know that the nurses are taking the new information and they're applying it every patient, every shift. So when we go live, we'll have the bedside companion tool, and then we'll have this RN audit tool that makes sure that they're following the steps. Did you review all your vital sign criteria, including respiratory rate? Haha, hopefully you charted that. And were there any abnormal values? And then if yes, did you go on to perform the bedside assessment, get your orders, start your 1 hour bundle? And so that the nurses will be self-auditing, making sure that they met all these steps, entering the note, etc., to make sure it's all there and that nobody is falling through the cracks. And then once we get the hang of this, the audit tool, I think, will be able to go away. But hopefully by the time that we get all the full EPIC build, this is just going to be second nature to these nurses following all these steps, and then they'll be able to document all of it into EPIC and those flow sheet rows to capture it in real time. Simple. Thanks, Christa.
I'll turn it over to Courtney Martin. And thank you, Jenna, for really pointing out that you can do all of this without having it in your EHR.
Yeah. Incredible presentation, Jenna. Really remarkable work. And thank you for, I might be connecting with you myself after, because it was just really remarkable stuff. Great tips and everything. Well, I'm honored to be here. My name is Dr. Courtney Martin. I am an OBGYN general by training. I also do some OB critical care work, and my passion is quality and safety, and have been honored to work with this incredible group of people and on the sepsis campaign. I'm here with Daisy Ramos, who was an incredible colleague that I worked with at Loma Linda, and where we built incredible enhanced sort of EMR tools that we're going to show you today and talk about nurse-driven care. And as much as I love my physician colleagues, I think that nurse training is incredibly lent towards following protocols and standardized care. And that is really how we improve safety and sepsis and other maternity outcomes. And so by implementing nurse-driven care, we're able to follow these guidelines and plans, and then we involve the doctors when medical decision-making is needed. By reducing standard clinical practice variation, we're actually able to really improve outcomes. Next slide. So what we're going to be showing you is some of the enhanced EHR screening tools that can be helpful as you're trying to identify both if you have the ability to build these, but they're even helpful on paper and in person. So first is going to be, it's really important when you're identifying somebody with severe infection, screen positive, that you've said, we think there's an infection here, right? So the bedside evaluation is done. And if the physician comes to the bedside and we say, you know what, this is hemorrhage that's maybe triggering this tachycardia and tachypnea, or this is something else, then we say, okay, we're going to continue to monitor. But if we say, yes, we believe this is infection, that's your time zero. That's incredibly important to get locked in somewhere. And in our EHR toolkit, it actually starts a clock that people can look at and counts down, because all of us know in practicing OB, both as a physician, advanced practice provider, or a nurse, that time melts away. I think of examples when you're pushing with a patient and you feel like, I've only been in here for 10 minutes and it's actually been an hour, right? So things go fast. The same is true when you're trying to get antibiotics on board, fluids. And we know that the data is clear. The sooner you get antibiotics on board, and the better outcomes for patients. And every hour delay of antibiotics increases mortality by 8%. So we got to get it on. Time zero is critical. So do you suspect infection? This is showing you how to set up an electronic time zero that then triggers your best practice advisories. And then also we included chorioamnionitis IAI. So it may seem difficult to differentiate the two, since, as Dr. Main mentioned and the toolkit highlights, over 60% of patients with IAI and chorio will trigger a screen positive. So how do you know when to be concerned or not? We've gotten into that. I'm sure we'll discuss that more throughout this project, but it's important to say that we don't just say, oh, it's just choreo, and we don't pay attention, because those patients can get very sick. So we included them that anytime a laboring patient has a 102.2 or higher, that automatically puts them into a time zero as well, because we want those same parameters for getting antibiotics on board for them as well. And then, of course, the temperatures 2 apart with fetal tachycardia and or leukocytes greater than 15, less or 4. So these, you could see the bottom 2 are actually IAI choreo screening criteria, and the above 2, the first one is going to be, do you suspect infection after that bedside evaluation? And then really using your order sets. That's going to be critical. A la carte ordering is not as effective for many reasons. You get clinical practice variation, but on many of the order sets, and hopefully you all build these too, we have specific flags that tell our pharmacists, this is an infected patient, she's pregnant, we're worried. And so they change it to be IV pushes. They hurry up and get the antibiotics to you if they're not in the Pyxis. So if you actually go to our next slide, we can show you some more about that. So screening and identification as a part of our EHR is critical. So remember, the EHR can be an important tool because we have so many patients on our floors, both as physicians and nurses, charge nurses. You're trying to monitor, but the EHR can, with machine learning and AI tools, screen patient data to identify sepsis or screen positive criteria with nursing validation. And so why that's so important is mute scores that show up can auto-calculate. That is so much faster to see an abnormality on your grease boards than it is to have to hand go in and look at everyone's labs or vitals, or rely on individual nurses to say, hey, this is a problem. When we build systems for safety, we want to make sure we have safety infrastructure that is independent of people remembering things, because we all get busy. You might be focused on one patient. The unit ratio might be out of ratio for a little bit, or you're busy trying to manage a lot of things. And so we see when multiple patients are sick, or you have a lot of busy units, you cannot rely on individuals as much. And that's not a personal character flaw. That's just the reality of what we're taking care of. So having a structured approach that empowers nurses to assess and understand, use the EHR quickly while maintaining physician oversight, in many of our opinions, is the path to safety. We want to be able to keep nurses in scope by saying, okay, is there medical decision making here? If I have objective identification with the help of the EHR, excuse me for the typo there, then you have like a heart rate elevation, respiration rate or tachypnea, temperatures elevated. We want to then recognize those as there's no medical decision making. These are objective. Then you have labor specific objective criteria, like someone's in labor and their temperature's over 102.2. Those are indications that would move us forward to say the nurse, especially in choreo IAI, could go get antibiotics with the help of EHR and decision support. So we delay recognition and we speed up treatment by utilizing nurse-driven pathways. We also remove clinical practice variation, where one doctor might want to do something, another one might not, even if there is standard care process and guidelines. So next slide. So what does that actually look like? It looks like education and teamwork to be able to get some of these things together. So I'm going to hand it over to Daisy here so she can describe this really great tool that she developed to be able to show what we're doing and what that means, and how that they've re-educated this so that we don't fall off after an initial sort of education and campaign. Daisy? I think you're on mute, Daisy, if you're, sorry about that. All right, I still think we're having some technical difficulties, so I'll speak to this while she's hopping on. Our first piece here you can see is just defining it and then what sepsis and obstetrics look like. But this is a specific recognize, react, and reevaluate specific to our electronic medical record, nurse-driven decision support care. So for example, you can see the screening tool will happen, what the standard criteria are, and then it will say react. So once they meet criteria, we use intentional terms that align with step 3 and our non-pregnant colleagues about time 0. And then we place the maternal order set, not a la carte. And we have a special order that I would highly recommend to all of you working on things like this, which is a per protocol. So when you do that, you have a per protocol order. This can work for hemorrhage, it can work for sepsis, that includes and encompasses all of your standing orders that then become active with one singular order that the physician does need to place. We were able to do it where it just needed to be placed at some point soon after initiation, but it did not hold up initiation of standing orders. So all of this does need to go through a process of approval at your institutions. In California specifically, we have excellent ability to do that within scope of practice. But you do need key stakeholders like physicians who are going to champion this and an administrative team that supports it as well. Then once you do that, you give the antibiotics within 1 hour of time 0. At different institutions, it might change, but this would be calling a rapid response, an OB rapid response, and then you reevaluate. So this is a nice tool that was developed with a QR code. Next slide. And you can see on there we have links to our guidelines, so the nurses can go back to those if we needed. So this is an initial OPA example. We like this one because we have workable actions off of this BPA. So the OPA will immediately trigger after qualifying values and validated values happen for a pregnant or postpartum patient's chart. Now you can set these up to be unit specific. You can set them up to be based on episodes of pregnancy, which is our some EHR sites or EHR things work, right? So different, Cerner might be different than Epic, but they do typically have an episode or a way to identify a pregnancy. And then what you do is you say, okay, this has been validated. It's imperative we talk about not validating improper values. That's probably one of the bane of my existence as a physician, where you see like severe range pressures and then they're like, oh, they weren't real. Well, then why did we validate them? We don't want to do that. So it's important when you're using HR, everything's validated and that you're making sure everyone's educated to that process.
Hello. Oh,
yes. There you go.
I'm so sorry.
That's okay.
Sorry. I'll take the next slide if you want to keep going, Dr. Martin.
Sure, no problem. So sorry, if you can slide back to that last one really quickly, you can see that it shows you the vitals and what met criteria, which is important, right? So you see the positive criteria here, heart rate greater than 110 when it was met. These also need to be sustained, not isolated events. And I'm sure that was something we'll go through as this project continues. You don't want just an isolated heart rate one time. It needs to be over 30 minutes. And then again, taking tachypnea very seriously. Tachypnea is never normal in pregnancy. And so anything 24 above, that's persistent as well. And then you can see that it shows recent vitals and where those happened. And then you can order right there, the order set and for the nurse standing orders. And then a physician OPA is similar and they can order it and see all the things that happened. Now, the other thing is we like to link our sepsis algorithms or severe infection algorithms right there so people can double check it if they have questions. Okay, next slide.
Thank you, Dr. Martin. I apologize for my technical issues. So on this slide, I wanted to talk a little bit about the RN-driven standing orders. So something that we've done in our facility, not just with sepsis, is really worked on creating standing orders for the nurses to implement, because we know it can be difficult to, get a hold of a physician right away, especially in cases like preeclampsia, maternal sepsis, where we can really get started without having to wait for the physician to put in the orders. So developing a per protocol order set really helps us get those things started. And like Dr. Martin mentioned, the a la carte ordering and asking people to remember all of the different components is really difficult. So creating that standing order set where everything is already there for the nurse to look through and accept without having to figure out like, yes, I need to click yes on this order and no on this order makes it so much easier for everybody. And the thing about the RN-driven initiative is we're not saying that we are not still communicating with our provider, right? We're getting the protocol started so that we can, in a timely manner, address the situation, get those antibiotics started within that hour. But then we're creating requirements to have that notification and document all of the notifications so that that communication is constantly happening. If there is a situation in which maybe the pathway triggered and the RN is having some issues with the pathway, like maybe when she does her bedside assessment, she's like, wait, I think actually the blood pressure cuff slipped down her arm and is at her ankles, or something weird is happening. It allows the nurse to validate all of those things. And we always want to empower them to, hey, if something is happening that is making you question this algorithm, that you're continuously communicating with your provider, that you're escalating care and you're using your cuss words to get the help that you need so that we can treat the patient timely.
Yeah.
And then we use a lot of like our OPA triggers that really have the prompts for the nurses to be able to know what to do next. So like Dr. Martin mentioned, memorizing all of the different components of the pathway is difficult, especially when things are happening very quickly. So our OPA triggers also help us guide us to what the next steps are and the expectations so that everyone's on the same page and knows exactly at what part of the pathway they are in. So the provider can go into the chart, can see the pathway is at this part, and so can the RN. Like if they're handing off, sometimes, you know, this is happening during shift change or maybe assignments are changing. They can look in the epic and see, hey, like this is where I'm at in the pathway. Next slide, please. So here's a screenshot of our order set and how we built it. A lot of these things are already part of our admission order set, like inserting an IV is already there, but we want them to insert a second IV. You know, doing continuous pulse oximetry, all of these things are kind of expected, but we need the order that's separate from our standing admission order that got placed on this patient earlier in her care. So like I mentioned, these things are already pre-checked. The nurse just has to kind of go through them, make sure that everything looks good, and then just click accept and okay and sign it per protocol. So there isn't that need to communicate right away as they are initiating some of these things.
I want to just highlight two things here. There were some questions about this, and if you don't have a current EHR setup, for that CBC, if you don't have a recent CBC, one of the things we've done until we have our new EHR build is just to have a standing order for nurses to order the reflex CBC with diff as a reflex if any of the other mute criteria are positive, as a way to get that ball rolling, right? Because we all know, we suspect it, but we don't have the white blood cells. So getting that done, and you can see here, it's also checked as a part of nurse standing orders to just get the CBC. The other thing I want to highlight is intake and output. One of the most important things in treating sepsis is going to be fluid resuscitation. And often units across all hospitals and all units aren't great at ins and outs, but particularly on labor and delivery, I realize it can be a challenge. But when we're talking about preeclamptics and hypertensive patients and sepsis, it is so critical. And if you have patients who have sepsis and hypertension disorders, it's even worse, right? Because we often tell you what, fluid restrict. But I want to just put this pearl in. I've been joking lately, you can always get an airway. Okay, we need to fluid resuscitate. That is how you prevent complications of sepsis. And we can't make those decisions clinically very well if we don't have ins and outs. So if that's a problem on your unit, which I suspect it is because it's been a problem on every unit I've ever been to and worked at, that is a really key place to start initiating some of your strict intake and output. And notice here that it's listed as every hour, which might seem overwhelming, but when we have someone that we're suspecting infection or has preeclampsia, that is a key step. So please note that little piece there as well. Let's go to the next slide. This is a hard stop for the order set that contains orders to address for antibiotics. So this patient does not meet criteria for suspected intra-amniotic infection, but if it's still applicable, then you can start it. Now, we all have people who are like, we know this patient has it, right? But they don't necessarily meet severe infection, step 1 positivity, but they have, fetal tachycardia and something else, right? They're just not right there. We still had a way for people to be able to have an order. And then this is, of course, is again, labor and 102.2, or they have those 2 temps. And so this is actually nurse driven. They did not need to call a physician. There's no medical decision making here. And these orders, we did show actually that we reduced the time. It was not statistically significant in our data pool, but we reduced the time to antibiotic administration, and it actually reduced the neonatal intensive care admission volume. So there is benefit to speeding up this process even before 1 hour. But definitely if you're not getting them in within an hour, that's a problem. So next slide. So closing the loop, that's a big one, right? So a second BPA in this example would show for the nurse if the patient didn't get administration of documentation of antibiotics within 30 minutes of time 0 or even longer. So you can see here, hey, this BPA comes up and goes like, the patient doesn't have antibiotics given yet. What's going on and why and what was ordered, as a reminder to like not just have the clock counting down, but to be sending messages to people who log in. So even the physician will get a BPA as well. Next slide. And it's important to close that loop again because time melts away, as I've mentioned. So this is another tool for those of you who potentially have Epic. I'm not sure if Cerner has the ability to do this or another sort of platform, but here this is called disappearing text. So we built this for our new process at Hoag when we launched the new 2-step back in August, where this red text is actually going to disappear when the note is signed. So it's a way to instruct your team of things like, hey, this is key updates. So use oral temp because that was a problem at our institution. The positive screen does not mean sepsis. We had patients getting listed as sepsis for any little thing. And so now we've really honed that in, and we have, when we really are positive, it's much more likely to be a true positive. The antibiotic should be started if it's suspected and clinical concern remains after evaluation. So we changed our antibiotics to Rosefin Flagyl or ceftriaxone Flagyl, excuse me, for a numerous amount of reasons, some of which are listed in the toolkit. And then again, blood culture is addressed here, lactates no longer. So you can do some education pieces in your notes. And then this is the bedside evaluation documentation for the nurse team. And our physician team has a similar disappearing text. Standardized templates for documentation, as mentioned in the earlier presentation, are key, but you can also slide some of these things in to help. Next slide. Here's a great example of the clock and the countdown to remind people and or stress them out, give them chest pressure as they see the clock is ticking. It does instill a sense of urgency if there is otherwise not one. One thing that we've noticed too is that if you have units where patients will be in an OBED or a triage and then they'll change to a labor floor or an antepartum unit, I would highly recommend talking to your team and looking at that process, because sometimes what can happen is everything's ordered and the plans are to do it, but then the patient changes hands and goes to a different unit, and now antibiotics aren't given. These are subtle things that happen that can delay processes. So what we've tried to institute is saying, like, if we have someone with hypertension or sepsis, we get the antibiotics on board and we get everything going before you move them. And that way a physician can keep eyes on them. Same is true for hypertension. We get the MAG started and the blood pressure down before you move the patient. Some tips about clocks and, again, just functional implementation strategies to prevent delays in treatment. Next slide. The other piece there that we're running out of time, but that you can have a navigator that we've done for hemorrhage, hypertension, and sepsis at different institutions that has all things sepsis, all things severe infection in one hover bubble. So nobody has to go 1,000 places to find the ins and outs, the temperature, the antibiotics, who's taking care of the patient. It's all in one spot. The labs are there. So really, really, really key. I think it's important to highlight, what do you do for initial education? It's listed here on the left. And Daisy is a master at getting education, but I think the maintenance is a big part. So Daisy, I'm going to have you talk a little bit about the maintenance here as we finish.
Yeah, so as we were getting ready to go live, we obviously spent a lot of time on that initial education, prepping people at staff meeting, having the RN super users on the floor, having the 24/7 like hotline in the beginning. So we put so much work into that initial education that we also wanted to make sure that there was a way to maintain it. Because as, time goes by, you have new staff, you have new people. We have a very large nursing staff. We have almost 200 nurses, and not all of them work full time. Some of them only work per diem. So then making sure that there's always that plan of how do we maintain it for our new staff? How do we ensure that our staff that isn't here often enough remember how to do this? A lot of that is built into Epic to help people remember a lot of components of it. But just making sure that you have a way that you're implementing some of those key components of education. So we have a really robust RN residency program. So we make sure that sepsis and simulation are embedded into our new grads. And then we do a review education, especially our high risk things like preeclampsia, sepsis is one of them, where we just make sure that we have like a routine. So, every year at this time, this is when we're going to hit sepsis really hard again. And I'm actually getting ready for our Q1 staff meeting where we're going to run some sims on sepsis, do some gamification to try to, kind of encourage people to remember like, hey, we still have this algorithm that we're using. We still have this flow that we're doing for our sepsis. Do you have any questions? What has come up since, the last time we talked about this? Because as something on here that says, don't be afraid to go live, you'll find that you can't be perfect. There's no way to be perfect. You're going to have to just go live. You're going to try to test the system for every single thing that you can think of, but you're still going to miss something, and that's going to be okay because you're going to find things as you are live with situations that you didn't anticipate. So making sure you have a way to address those things, and keeping a close relationship with the people who are building your system so that you can communicate with them quickly and maybe fix things on the spot.
And truthfully,
sure
just having like this big campaign and talking about it and noise around it, actually, I found increases the safety for patients. So the delaying, because it's not perfect, is actually going to delay your ability to get some infrastructure in place. And I love this saying from one of my current nurse managers I work with, paint the plane as you fly. Isn't that obstetrics in a nutshell, right? Like, don't delay, just get it going, have your framework. And then like Daisy said, things you think you have settled will not be settled, and every journey is different at every different institution. So even if we gave you our playbook, you would find it might not be the same as the challenges and things that you have at yours. Next slide. We have a green sheet that we use. This is the example of the one being used at Hoag currently because we don't have as much EHR built yet. This is sort of in the computer at Loma Linda, but this is a really nice way, and this is a way that we use it as an audit tool. So to speak to sort of the idea before, I agree, audits are incredible. We found out something completely different than what I thought was happening when we launched our this updated process in August. And I found out that some of our physicians are missing sepsis. I didn't think that was what was happening, but it was, right? Because they were explaining away hypoxia, explaining away low urine output as the baby's head's obstructing, right? No, these patients are septic, right? So as you go on, using a tool like this to help guide what the process is can also be helpful to use as an audit tool. So I would highly recommend something like this, whether it's in Epic or in Cerner on a computer or done by hand and turned in. And then again, really whatever works for your unit, we're giving you all these ideas and suggestions, and we're happy to share any of our builds. But if you have them too, we want to hear. The more people contributing this, the better. Again, the same noise around this process at every hospital doing it helps all of us. Next slide. So here's my other latest thing besides you can always get an airway and paint the plane as you fly is mute doesn't miss, okay? I've thought about making shirts. I will tell you in my experience as an obstetrician that also does some OB critical care, mute abnormalities, highlight specifically things are going wrong, maybe even before they're officially there. And I'll give you examples. Here you can see that this is a grease board column I took a screenshot of, and some of these are ones. Now, a lot of the ones will be white blood cell counts, but I can't tell you how many times a 1 is like a low SAT, and we have it set at 94 or less, right? So even on postpartum, if somebody's 94, usually we don't get too excited until 92 for a sepsis criteria, right? But somebody shouldn't be 94, 95 when they otherwise are normal. How many times we've diagnosed pulmonary edema, a little bit of heart failure, things that are going wrong by this mute criteria. If you don't have this set up at your hospital, I would tell you this is one of the greatest safety infrastructure pieces for sepsis and all other SMM prevention. Please get a mute score that's available to everyone so that it doesn't have to be calculated by people individually, but an auto-calculated on your computer so that it's visible to everybody. And consider using catchy phrases like I've been telling you to try to maintain and continue progress, make it memorable to people. We've started signing out the mute score at every sign out. If there's any abnormal mute scores, reviewing them on the safety calls and instituting people to go check these patients out, because often we find that there's something brewing before they get really sick. So this is a little tip as well that you can set up with EHR tools. That is an incredibly important safety infrastructure piece. Next slide. And then again, nurse-driven care, nurse-driven QI. I think that there's 2 keys to having a robust safety program at a hospital, no matter the size. Number 1 is you need an empowered dyad that's a nurse leader, a CNS, an educator, a manager, and an engaged physician who cares and can move the needle with their physicians. If you have one and not the other, we won't get anywhere. And I think anyone who's on this call and has had success knows that to be true. And I'm so grateful for my time working with Daisy and Kim at Loma Linda and my current team and some other hospitals as well. You have to have this team to implement things on both sides. And then also is nurse-driven QI. It cannot be just physician peer review. You need to have nurse-driven quality improvement metrics and having examples of how to look at this. This is an example of a slide deck from our performance at Hoag that my nurse leader running a clinical ladder, professional governance for sepsis, and I have an adult sepsis colleague that works with us, showing all the code activations that met criteria and what we did and how many where the workup is pursued and antibiotics were administered on time. So we saw that we had 83% started within 30 minutes. We set our goal sooner, but we've been able to review every case through our nurses, and it helps us because a physician champion cannot also review all the cases and do all the things, but we can take this back to our physicians. So those are the 2 keys, but nurse-driven care and nurse-driven QI are irreplaceable. Next slide.
Courtney,
And then this.
Courtney, we're going to move to key points,
Yeah.
so we have to wrap up
Thank you
here.
so much. I know I was like, I think we're out of time, but thanks, Christa. Thank you.
No worries. So key points for our sepsis is infection with end organ injury. So that's the key point here. We want to review that screening flow chart and the teaching points with all of our staff and providers. We want to make sure that we have bedside evaluation in place as one of the most important steps of the screening pathway and that it's documented in the EHR. We don't want to wait for those EHR to be fixes to be done before we move with this process and before we educate to this process. We know in some of our institutions, EHR builds or updates can take forever. So there was a lot of presentations of different workarounds and things that we can do in the interim as we move towards those EHR builds. And a lot of times, as was mentioned in the last presentation, you're going to find those little hiccups where those things that you thought were going to work beautifully in the EHR aren't quite gelling the way that you wanted to. And in this lead up period where you're kind of using these different modalities, you might be able to find some specific tweaks for when it actually goes into the EHR. Nurse-driven pathways save a lot of precious time and it really streamlines care for standard diagnoses. Again, depending on what your facility setup it is and how your flow is, being able to get the attention of a doctor immediately is not always possible depending on what else is going on the unit. So how can we streamline this treatment and get those initial steps moving? Next slide. Oh, Action steps. So between this meeting and the next meeting, it's unrealistic that you would get all of these things done. Again, this was a 12-month collaborative that hospitals worked on. So we just want you to start thinking of some of these things as you're designing your own program of implementation at your facilities. If your team hasn't yet begun the sepsis bundle on any level or really got not very far in it, we do suggest that you complete the readiness assessment that did go out in this pre-email. That'll help you just kind of set the tone and lay a little bit of groundwork for how you're going to proceed with this project. Assess your current vital sign screening tool for obstetric sepsis. So whatever you're currently using now, do you have an obstetric specific screening tool, or is it just apply to all adults? Is it standardly applied, and does it address the value changes of pregnancy? Assess your bedside evaluation practices, and maybe there aren't any yet, and that's where you're starting. But have you created the standardized documentation for bedside evaluation of any kind? Do you have a protocol for next steps after a positive screen? Have you reviewed and updated your sepsis order sets in the EHR or elsewhere? And have you considered nurse-driven pathways as appropriate in your facility? Next slide. So our next session is going to be on February 17th at noon. We're really going to go over treatment considerations in that session. The topics are going to be choosing antibiotics, choreo, and treatment of sepsis. So we would love to hear your questions ahead of time, your antibiotic questions, before that session, so we can make sure to address as many of them in the panel as possible. So if you could submit those questions to Ruhi, her email is right there, by January 26th. We will try to field as many of those as possible during the panel discussion. We do have about 10 minutes for questions, and there's already quite a few in the queue. But if you do have an additional question, you want to see if maybe we can get to it, please go ahead and utilize the Q&A box. We won't be asking any questions with hands raised. So just so that's clear, if you could go ahead and put your question in the Q&A box. So let's move to the first question. It says, this is for Elliott. Many patients with choreo meet the criteria for step 1. If we don't have a recent 24-hour WBC, we should redraw at that point, or they've already met step 1 by 2 other criteria, excluding WBC. Is a redraw unnecessary?
So this is an important question, and it involves in the evaluation of end organ injury, because a CBC is not only about white count, it's also about platelets, which is part of the assessment of coagulopathy for end organ injuries. So essentially, if you have a step 1 positive, you want to draw just basically a chem panel and a CBC.
All right, next question. I'm an ED nurse educator that was in L&D previously. I try to bridge the 2 departments. Does your hospital have the ED utilize these protocols, or do they defer to an OB consult? Do you think this is something that ED nurses could do as well? If these patients are postpartum, they remain in the ED until they receive a bed on a medicine unit. So our nurses could be caring for these patients for hours and sometimes days.
I can answer that. I absolutely think they can use them. We have examples historically of at both of many of the prior institutions I've worked at where our ED uses both the 2-step screen and uses a postpartum hypertension order set that's designed by our obstetrician team in quality to ensure that we're doing and following through. The other piece is for those of you who have the ability, this is where, yes, you could do an OB consult, also considerations in your infrastructure of how you allow or what gestational ages you allow to your OB-ED, and even consideration for some postpartum within the first 2 weeks of delivery or so. So there's lots of ways to approach it, but absolutely partnering with your ED is important both for education and for infrastructure build. Think about how important it is to maintain that safety and that clinical practice variation reduction in an emergency department where there is less knowledge. So absolutely highlight that, and would be happy to share any of our prior tools.
We're thinking of adding a small segment into one of our later sessions about ED use and the role of the ED in maternal sepsis. So stay tuned for that.
Elliott, this question says, I remember that lactate values in active labor were abnormal if above 4. Is this info still correct?
Lactate in labor is very controversial. Just the fact of being in active labor or pushing raises anaerobic metabolism and therefore raises your lactate level. So it's clear that 2 is actually fairly normal, 2 to 3 in active phase labor. It's a little ambiguous about how high is abnormal. We generally consider 4 to be concerning, but we're not recommending drawing lactate unless you assess the patient is very sick or they have abnormal end organ injury labs. And so then I would be concerned. Now, one of the issues about lactate in the setting of choreo, and we're going to talk about this more next session, is that drawing lactate can set off the diagnosis for sepsis in SEP1. And so you want to be a little cautious about doing that because that'll open up a whole set of new pathways. So 4 is abnormal, but don't draw it unless you really think the patient's sick.
And Elliott, just to tack onto that, it says, what literature exists to support waiting 1 hour postpartum before drawing a lactate? Our hospital currently uses it.
So Melissa Bauer has some articles on that and showing that that the falling of lactate from anaerobic metabolism takes 30 to 60 minutes. This is supported actually by exercise physiology and by people who run marathons. And I teach that having a long labor and pushing is like running a marathon. But it goes away pretty quickly, the lactate, within 30 to 60 minutes.
And those citations are in the toolkit as well, just for everyone. Courtney, is the 30 milliliter per kilogram fluid bolus in addition to the 1 to 2 liter bolus given at first?
Yeah, so it's another great question. I think in general, if you have somebody who is screen positive for infection, then you would at first do that 1 liter is how our order sets are. And then you can do the 30 milli per kg, but you usually combine the total. So if you already gave a liter, then you could see what the calculated is. But I say that with a caveat of experience now taking care of a lot of septic patients. After that, if you have somebody, and again, this is where the ins and outs are so important. If somebody's coming into this dehydrated or dry or under resuscitated, or you don't know their ins and outs, you can see why it becomes extra challenging. So I would err on the side, if you believe someone truly to have sepsis and you have met criteria, not just severe infection positive, you need to be aggressive with fluids, maybe even on top of that 30 milliliter per kg bolus, because they may already have been very dry from a long labor process and under resuscitated going in. So that's the caveat, but absolutely, we don't want to overload people. So in the suspected infection, it's important to stick to the more conservative amount, but once you confirm, you have to be aggressive.
So I'm going to add to that the 30 mils per kilo, again, is an ideal body weight, which is not your current body weight, but it's also for folks with septic shock.
Correct. Yeah. So that's why you don't do it in the first part.
Yeah. So it's not everyone with sepsis, it's those who have hypotension, and that's a very dangerous setting.
Yeah.
And then this is for Daisy and Jenna. How do you get your providers to get involved?
You find one that's very passionate. So as long as you have at least a champion that's either passionate about QI, passionate about that specific topic, they are really going to help anchor that and get that, get that to the rest of providers. We don't have private physicians, so we don't struggle with some of those issues with having different provider groups. But for all of our pathways, all of the things, we have at least one provider who is passionate and attends all of the meetings and can help really disseminate that information to the rest of the team.
I think that's a key step for any QI project, but specifically for this is that you need a physician champion and a nursing champion.
For those of you who have private physicians and feel like it's difficult to get engagement, one of the things that's worked for us, if you have a hospitalist program, that is a little bit of a stopgap in the sense that we've turned the hospital's team into the champions. And so they run the responses on the bedside evaluation and entering the orders. We don't actually go through the community physicians for those. And so that's a way too to kind of get engagement as a stopgap. Now, if you don't have a hospitals program, I think, again, a champion using med staff, using some of your programs. But one thought is if you have a hospitals program is to really make them the champions and keep it with a smaller group of doctors who have an onus to the hospital system.
And then I do want to add for those in California, sometimes looking at your provider level data can help you find some champions. It's kind of a way to help identify champions when you can look a little bit at who's more active in some of your quality improvement metrics. So we are going to go ahead and launch a poll. This is the first time we have tried this sepsis sprint modality before, where we're really deep diving into actual implementation. And so we hope that you enjoy it. If you were looking for deeper consideration on education and like the basics of the toolkit, please go back to all of those recorded webinars where we really focused on the whys and where everything came from. This was really supposed to be focused on how to help you implement it in your own facilities. And we hope that we've done that. I think all of our presenters did a wonderful job. And thank you so much for being here with us today. And thank you to all the attendees. We will see you on February 17th. The recordings and the slides will be up on the CMQCC sepsis webpage within a week.
And if you have any questions between now and February 17th, please don't hesitate to reach out to me directly at rnath@stanford.edu. And if you'd like any of the materials that you saw today, the presentations will be available, like Christa said, but you can reach out directly to the presenters themselves. Thank you so much for joining us.
Please give us your feedback. There's only 2 questions. Shouldn't take more than a few seconds. We really want some feedback.
Thank you so much.